Hello, my name is Daniel Escalante. I am going to talk about direct oral anticoagulants for thromboprophylaxis in ambulatory patient with cancer. Definitions: Anticoagulants are medications that help prevent blood flow clotting people at high risk of blood clots, such as people with cancer can take blood thinners to reduce the chance of serious illnesses like heart attack and stroke.
Patients with cancer have an increased risk of venous thromboembolism, but parenteral thromboprophylaxis is not routinely recommended in practice guidelines because the absolute risk reduction is modest and parenteral thromboprophylaxis is associated with an increased risk of major bleeding as well as the inconvenience of daily injections. Could a direct oral anticoagulant such as apixaban, used as a thromboprophylactic agent in patients with cancer, offer advantages over parenteral agents, particularly with regard to convenience? The randomized placebo-controlled double-blind AVERT trial included ambulatory patients with cancer who were at intermediate to high risk for venous thromboembolism with a Khorana score of 2 or more. The Khorana score has been validated to identify patients with cancer who are at elevated risk for thromboembolism. The trial patients were randomized to apixaban for thromboprophylaxis before chemotherapy or to placebo before chemotherapy. The primary outcome was objectively documented venous thromboembolism over a period of 180 days. In a modified intention-to-treat analysis, venous thromboembolism occurred in 4.2% of the 288 patients in the apixaban group and 10.2% of the 275 patients in the placebo group. The number needed to treat to prevent venous thromboembolism was 17. The main safety outcome was major bleeding. Major bleeding occurred in 10 patients in the apixaban group and 5 patients in the placebo group. The authors conclude that apixaban at the initiation of chemotherapy resulted in significantly lower rates of venous thromboembolism than did placebo among intermediate to high-risk ambulatory patients with cancer. The rate of major bleeding episodes was higher with apixaban than with placebo. Full trial results are available at nejm.org.
Applications in medicine were searched for studies that examined the benefits and harms of anticoagulants in people receiving cancer treatment who otherwise had no symptoms or conditions to suggest that anticoagulants were definitely needed.
Hi, I'm Alok Khurana. I'm a medical oncologist at the Cleveland Clinic with an interest in thrombosis, and I'm here at the American Society of Hematology meeting in 2016. A couple of the abstracts that we're really excited about, one of them is most of them are looking at the use of direct oral anticoagulants. These are drugs that have come onto the market in the last 2 or 3 years and are much more patient-friendly and easier to use than older anticoagulants like low molecular weight heparins and warfarin. The challenge has been with these drugs, they were primarily tested in the non-cancer setting, so in atrial fibrillation or prevention of ET after orthopedic procedures. Finally, this year, we are starting to see data utilizing these drugs in the cancer setting. And what data has been presented at this meeting and earlier this year all suggests that the drugs are safe to use and they may be effective in preventing VTE. One of the abstracts is from the University of Minnesota, and they're looking at several thousand patients with cancer who have atrial fibrillation and the use of DOACs in those patients. And they found that DOACs were just as safe as warfarin, if not safer, with maybe less risk of bleeding. And they were able to prevent both ischemic stroke and arterial events as well as venous thromboembolism events. That's very encouraging, and it suggests that the ongoing trials of prophylaxis, such as Cassini, which uses rivaroxaban, and AVERT, which uses apixaban, which are being run in multiple countries, may have the potential to change risk of ET in the future in cancer patients. Other abstracts have looked at extended use of rivaroxaban in treatment of VTE. I presented some data looking at rates of recurrent VTE in patients who stayed on rivaroxaban after 3 months and after 6 months. And in both those studies, we found that there was no increased risk of major bleeding, but there was a reduction in the rate of recurrent VTE. And this supports the findings in the clinical trials, but because our data was in the real-world population, we feel that it suggests that this is both beneficial to patients and safe in the outpatient setting. Finally, we looked at rates of major bleeding between cancer patients and non-cancer patients, also with rivaroxaban in a Department of Defense cohort. And we found that there was no increased risk of major bleeding. And in fact, rates of major bleeding in the cancer population were just the same as in the non-cancer population. So taken together, all of these data suggest that direct oral anticoagulants are going to be important for cancer patients in the future. We should support ongoing studies, and we feel that the use of these drugs is both safe and beneficial in this population.
Pros and cons. Pros: lower rate of stroke from bleeding in the brain tag warfarin. Lower rate of major bleeding tag warfarin. Lower rate of stomach uptake tag dabigatran. Cons: it is administered into daily dose, which makes it more feasible to miss a dose.
Before we close out our video today, do you have any additional information that you believe patients with cancer should know?
Certainly. I think the first thing is that I've seen a lot of people get very distressed when they've had a diagnosis of a clot in their cancer journey because they think, wow, this is a complication, that's a terrible sign, things are not going well. This is so common in cancer that actually I see it as just a normal part of the cancer journey. So I would say don't read anything into it. This is normal. In the same way that you may feel nauseated with certain chemotherapies, you may lose hair with certain chemotherapies, you may get infection with certain chemotherapies, you may get a clot with certain chemotherapies. This is all normal. It's important to have information because when you are first diagnosed with the cancer, your mind is spinning. You're going through the shock of the diagnosis. You're wondering, what am I going to do? How am I going to tell my family? How am I going to manage? And you don't take all the information in. So sometimes you need to get information more than once. What I'd say is there's a couple of really good resources. First of all, there's an excellent video which I and colleagues were involved in making called Cancer, Clots and You. And that was made by Anticoagulation UK. It's on their website. And it's also on the website of Thrombosis UK. So I think that has excellent resources. And that video is really nice. It really explains things carefully. In fact, what we found in our clinical practice was that it meant that people were presenting sooner when they had symptoms of blood clots. Previously, it would take 9 days before someone would seek medical help if they had symptoms of a DVT or a PE. After using this video and putting it into our clinical practice, that number had reduced down to 3 days. So we reduced the rate or the speed at which people presented by 2/3. And I really believe that that saved lives. Also, the presence of that video as video cards in the chemotherapy suite, in outpatients, increased the awareness of staff as well. So I think they had a much lower threshold for questioning whether a patient had a clot. So we need to involve our healthcare professionals, but we also need to feel empowered ourselves to ask about clots, because it's our bodies, it's our health, and therefore we have every right to make sure that if we have this normal part of the cancer journey, we need to pick it up and get adequate treatment for it.
Also applying in Ecuador. In Ecuador, people with cancer who are undergoing systemic treatment, any drug that is carried through the blood, through the body to find, damage, or destroy cancer cells, including chemotherapy, radiotherapy, immunotherapy, and treatment direct, have an increasing rise of developing blood clots. Conclusions. Current evidence on BQA thromboprophylaxis suggests that the heart from major bleeding might outweigh the benefit from reduced venous thromboembolism in all patients with cancer receiving chemotherapy, targeted therapy, immunotherapy, or radiotherapy alone or in combinations. Thank you.